Good afternoon, everyone. I would like to introduce myself. I'm Dr. Alyson Jones. My specialty is physical medicine and rehab. And today I want to talk to you guys about stroke rehabilitation. The feed is running live. You guys can ask questions and we'll answer those questions at the end. All right, here we go. So I just want to give you guys a quick review of stroke. Each year, 795,000 people experience a new or a recurrent stroke every year. For 610,000 of those, it's their very first event. So that's a lot of people having new strokes every year. The other side of it is 185,000 people have a recurrent stroke. And part of the problem when patients come into the hospital, once you have one stroke, we let them know that there's a higher risk of having a secondary stroke. So we try to teach them modifications of their lifestyle and control of any medical issues so that we can try and reduce that recurrent stroke. Even though this amount of people are having strokes, people are not dying as often as they used to in the past, so more people are living with disabilities. So that is something that we have to deal with as well, because having a disability and living longer means more rehab techniques that we have to work for these people. So a stroke causes 1 in every 20 deaths in the United States. So that means that every 40 seconds somebody has a new stroke. But someone does die of a stroke every 4 minutes. Stroke is the leading cause of disability in the United States. 20% of people that have strokes have to go to skilled nursing facilities and nursing homes. And 30% of people that have strokes remain with disabilities the rest of their life. So I put a slide up to show you guys where most of the stroke deaths occur between 2015 and 2017. And as we all know, the South, the stroke belt, you can see here, Louisiana, Mississippi, and Alabama have the highest rate of stroke deaths. And we wish we could do things about this, continue to educate people, modify our lifestyle, but it's definitely still a work in progress. So stroke and money, again, it's the leading cause of adult disability. It costs insurance companies and hospitals $71 billion a year. Those costs are divided up between the hospital stay needed right after they have a stroke, then the secondary place they go to, whether it's inpatient rehab, long-term acute cares, or skilled nursing facilities and nursing homes. The patient also loses money, average of $33 billion a year. Costs also come from going to doctor visits after they get out the hospital, equipment they may need, outpatient therapy, home health, and different treatment for things that arise such as spasticity. Also, the new medicines that they may need. And unfortunately, the cost of stroke does not decrease as time goes on. And the more disabling stroke that you have, the higher the cost that it incurs for you. So I just want to talk about what does it mean to be disabled. Number one is the organ that's not functioning correct. In this case, it's the brain. So that is the impairment that people have. Then the difficulty that they have with doing a task, that's called the disability. And then the disadvantage that they have from the disability is called the handicap. So what do we try to accomplish with stroke care? We try to reverse the deficits caused by the stroke and minimize the impact on that patient that they cause. We also try to prevent, recognize, and manage secondary medical conditions that can occur with strokes. We want to maximize their independence and ability to perform activities of daily living, such as just eating, getting dressed, going to the restroom, walking. We also like to facilitate psychological and social adaptation and coping for the patient and the family. You know, having a stroke is just not difficult for the patient involved. The family has to adjust their lifestyle to try to help their family member that have had the stroke, and that can put a lot of stress not just on the patient but on the family as well. And ultimately, we just want to let the patient know that, you know, this is not the end of your life. We can enhance the quality of life that you can have with the stroke with different modifications. So what happens when you first have a stroke? The acute phase is when you go to the hospital. Most likely you're going to go through the ER, you're going to need an ambulance ride, you're going to meet the emergency room physicians, the neurologists, interventional radiologists if needed. Each hospital most of the stroke centers have a special code that they use. Here at Memorial, we say code BFAST. That way everybody knows that somebody's in the emergency room with a stroke, and they try to act on it fast, because the faster you can preserve brain tissue, the better chance of a recovery you're going to have. You may have heard about the medicine that you can get in the ER if you get there timely. It's called TPA. It's that clot buster. So again, I would like to urge anybody that's listening, if you have symptoms of a stroke, get to the emergency room as fast as possible, because that does make a difference. Some facilities can actually go in and remove that clot that may be causing your stroke and get it out, and again restore blood flow and give you a better chance of having a better prognosis after a stroke. Rehab begins in acute care within 24 hours of your arrival. So that part is what we're going to keep talking about here today, because it's not good to just stay in the bed and rest. You got to get up and start moving, and whatever deficits that the stroke may have caused, time to reteach those muscles and help your brain recover from that. So what happens when people have a stroke? The common things, you all probably know, you get paralyzed on one side or the other depending on where your stroke was. Paralysis also includes your swallowing muscles, and that causes something called dysphagia, which is basically you have difficulty swallowing. So that's included with the paralysis. People will have sensory disturbances, which basically mean they're numb on one side, or they feel a little bit of extra pain, or things that don't normally cause pain, like just getting a light touch can cause pain. So your nerves can sometimes go out of whack and start sending signals that normally you don't feel. People have problems understanding language. Some patients have no idea what you're saying to them. Other patients know what you're saying but can't get the words out. So those are different things that we work with therapy. Those patients that have recurrent strokes do tend to get dementia, because that's brain tissue that has died over multiple times. Each stroke, you do have brain tissue that dies, so that can lead to dementia and memory problems. People get depressed after a stroke, and they also can experience something called pseudobulbar effect, where they cry and they don't mean to cry, or they laugh and they don't mean to laugh, so we address that as well. And many patients can have visual problems, not being able to see, and vestibular deficits, which basically means they get dizzy and have problems with things like vertigo. So again, back into the acute hospitalization phase, you're going to get evaluated by physicians, of course, the nurses who are the caregivers that are around the most frequent time. You're going to get physical therapy, occupational therapy, and speech therapy evaluations, and all those providers are going to want you to start moving right away and promote you being able to do things yourself again. You can't stay in bed. We want you to change positions in bed. We don't want skin issues. The therapists are going to do passive range of motion on the side that's affected. You may not be able to move it yet, but the therapists are going to keep moving the weak side so that it maintains its range of motion and not get stiff, along with teaching the strong side how to do things that the weak side can no longer do. And again, we're going to get you up and moving, sit you up, stand up, make sure we have the correct diet if you do have swallowing problems, and take care of your skin and spasms. So there are two different types of recovery. The first is neuro recovery, which is your brain. That's going to start to happen on its own. Usually within the first few weeks, you have an area of your brain that's greatly affected by the stroke, and then you have a secondary area. This is called penumbra. So basically, this penumbra can heal really fast, and as it heals, some of your function is going to return. So we are happy when that area starts to recover and you start to get movement back in. The functional recovery is what therapy helps the most with, and that's just teaching your muscles how to do things since the stroke happens. Again, this is the part that's most helped by rehab. So again, the neuro recovery is the resolution of edema that can happen when you have a stroke, toxins removing out your body, and the neurons that were minimally damaged, again, they start to recover. The majority of recovery after a stroke happens within the first 3 months, but again, many patients can continue to recover for up to a year and a half even. The improvement in your independence is going to depend on areas of self-care and mobility. So basically, what can you do for yourself? Can you get dressed for yourself? Can you walk on your own? This is going to depend on how intense your therapy is and how much you're putting into therapy. So 10% of patients have complete recovery. So there are lots of patients that come in, have a stroke, and within a day or two, they're back to normal and they can go straight home. 10% of these patients also have such severe stroke that they're not able to participate in therapy, and those patients do tend to go straight to nursing homes or skilled nursing facilities. But the middle portion of those patients, about 80% of them, can benefit from continued therapy, whether it's inpatient rehab or going to outpatient therapy or getting some home health come out to the house. So who is the team as far as the inpatient rehab side? You have myself, the rehab physician, again, the nursing, the physical, occupational, and speech therapists. You have case managers and social workers, nurse practitioners, neuropsychologists, dietitians, and respiratory therapists. What we, again, hope to do is restore you to your maximum ability and mobilization, help you regain your independence and confidence, provide measures to prevent falls and ensure that you're safe after you have the stroke, educate your patient and family about things to expect, and facilitate your return back to home and back into the environment. So what things specifically that the nurses work on? They work on your bladder and bowel. A lot of times after a stroke, you just can't get to the restroom in time, and so the nurses kind of help with that. We may have to sit you on the commode a couple times every 3 hours just to keep you from having accidents. The nurses also work on skin care and wound care just to make sure everything stays healthy, because cleaning can be a little difficult after you have a stroke. Again, pain management. A lot of patients, are elderly when they have a stroke, so they can have arthritis premorbidly or beforehand, and the walking is kind of thrown off when you have a stroke, so people can have arthritis flares. So we work on making sure to keep their pain under control so that they can give the best that they can when they go to the therapy gym. We try to prevent falls. Some patients forget they had a stroke, or if they have issues with their thinking after they have a stroke. This can be something serious in a hospital that can lead to further injury, so we definitely want to prevent falls. And we work on things such as visual neglect and impulsivity. So the physical therapists, they're going to work on your ability to manage a wheelchair, to walk, to get from one thing to the other, called transfers, basically getting out your bed and get into a chair or get into a wheelchair. They're going to build your endurance back up. Most people can have a step or two or more into their house, so we work on stairs and just seeing what equipment you need when it's time to go home, and making sure you can get in and out of a bed safely. Occupational therapists, they work on eating, grooming, being able to bathe, like I said, getting dressed, going to the toilet, and making sure that you have the right equipment again to get home and be as independent as possible. The speech therapists, they're going to work on the ability to think, how you comprehend things, how you express yourself, how you interact with your family members and other people, being able to problem solve. Can you get out the house safely if you've had a stroke and you're having difficulty thinking? How is your memory doing? Can you swallow? So it's several aspects that all these team members work on after a stroke. People tend to also get dehydrated sometimes when they come into the hospital. with a stroke, because when you have problems swallowing, you tend to cough, and patients try to avoid things that can cause problems, so a lot of them get dehydrated. So we have to make sure they're on a correct diet so that they're not scared to eat or drink, and that they can safely eat or drink without the food going down the wrong pipe, also known as aspiration. We also have neuropsychologists or licensed clinicians to help with the depression side of having a stroke. We talk to them, we give them strategies for coping with whatever they may be struggling with, adjustments, and we also continue to just work on their ability to cope and provide them with feedback and different things that they may need to feel better about having a stroke. Also important with stroke therapy is the respiratory therapist. We strengthen your lungs, and occasionally for severe strokes you may still have a patient on a breathing machine or still have the trach, and we work on weaning that off. Other companies that are involved are orthotics and prosthetics companies. You may have seen a patient with a foot brace or splints, so we do utilize those companies to help with providing range of motion and whatever they may need to help them ambulate. I'll keep going with different providers that are involved. Case management, the social worker will help discharge plan, make sure that all your family members know what's going on so that we can get you home safely. They update your family in case they're not around 24/7. And give you resources into the community that can also aid when you go home as far as how you can keep getting resources to aid in your care after you have a stroke. So just some other problems that patients with strokes can have. There's something called neglect, where the patient that has a stroke doesn't pay attention to one side of their body. So we do different things to help with that. We move things to that side of the room that they may be ignoring. We cue them to remember to look to the side that they, again, are ignoring. And we kind of like force them to pay attention to that side of the room. And again, medications are needed for people that may have dementia, recurrent strokes, and we give them Aricept, Namenda, or some of the common medications. All right. And again, other problems they may have would be the pain issues. There's something called central post-stroke pain, where patients just have pain on that same weak side of their body that are just out of proportion to what they should be feeling. And different medications are used to treat that, including just regular opioid pain medications, some anti-seizure medications, and different things like TENS unit, which is the little machine that we use to kind of shock your arm. So there's different things that we can do to try to help that. And then also people have dizziness. That we have a therapist at outpatient here that helps work on that training. He has a special machine that can help with the vertigo symptoms and the dizziness that patients can experience. All right. Other common medical problems that you may not realize that people have, kidney injury. Again, that's going to come from being dehydrated from the swallowing problems that they may have. A risk factor for strokes is high blood pressure, so we have to continue to adjust blood pressure once patients are admitted, but we can't drop it too low, because too low blood pressure can actually make a stroke grow. So there's a little area that we try to keep your blood pressure in while you're on therapy and in rehab, and then we work on reducing that after you get out the hospital. Again, people are frequently depressed after a stroke. We get bladder infections because hygiene can be difficult to keep up with after you have a stroke. A risk of blood clots in your legs is a high risk factor, especially on that paralyzed side. So we have to do things preventative to keep those from happening. People tend to be anxious and nervous in the hospital, so we also get patients with GI bleeds occasionally. People have headaches, seizures, and again, their osteoarthritis may flare up sometimes when they're in the hospital. So once people get out the hospital, some of the issues that they may deal with, can they go back to work? I'll see patients in clinic for months after their stroke and keep up with that therapist that they are seeing to try to figure out when's a good time for them to return to work, if any. When can they drive again? When can they have a physical relationship with their spouse? Spasticity, tight muscles. You guys may have seen a patient at some point in your lives that have had a stroke, and you see someone with an arm that's stuck like this. That's called spasticity, and that can lead to impairments in itself. So we try to prevent that from happening from the time they get into the hospital to years after they leave. It's an ongoing treatment that we try to work from that stiffness from happening. Problems happen as you get older. That weak side will start to develop osteoporosis at a greater rate than the stronger side. So those are further things we have to deal with and try to prevent falls, because we do see patients that have had a stroke at some point in the past and they fall and then they end up with a hip fracture or some other fracture. So it's a lot of education that's ongoing. Other issues that patients tend to have later on after the stroke, rotator cuff injury. People are prone to rotator cuff tears just as you get older in general. So when you have somebody with a weak arm, and if anybody pulls on that arm, they're really prone to get rotator cuff tears, and it can lead to chronic pain in that shoulder. So factors related to improved outcome, getting into increased functional skills on admission to rehab. So if they're able to do more when they first come in, then that's a good functional outcome that they'll continue to improve once they leave. Getting started in rehab as soon as possible, whichever form that it may be, and having a team of therapists that communicate versus therapists doing separate things all the way around. So measures that that you're having a successful rehab is if things are returning back to normal. That's a good sign. Being free of pain and distress and impairments. Being able to remember and being able to have good communication, return of your mobility and independence, and just an overall improved quality of life. That's all that you therapists try to provide for you once the stroke has occurred, and we try to get you back home. All right, so now I'm just going to talk about some of the fun things that are out there as far as stroke therapy. We'll go through a couple of them on the slides there. So pharmacy-wise, before I go to the cool things, on the pharmacy side, SSRI is a medicine like Lexapro or Prozac. These medications, even though they're for depression, have been shown to improve your strength after a stroke. So you'll see that it's kind of like a two birds and one stone medicine. If patients come in, I'll tell them, hey, this medicine is for depression, but it can help you get over your stroke better. I may know that they have some depression on the side, but I'll spin it so to let them, try this medication so that we can get them through the rough period and get their strength back, and it also help their depression at the same time. Some patients come in who are real lethargic and sleepy, so we have medications like Ritalin and Provigil to just kind of give them a little boost. It's like a little coffee boost, and it helps them pay attention and be more alert to be able to participate in therapy. And then again, we talked about Aricept and Namenda for patients with dementia. So some of the therapy techniques that we have, CIMT it stands for constraint movement therapy. Basically, we tie up or restrain the good side some kind of way so that it's forced for you to use that weak side. Some people will just want to give up on the weak side and just use the good side, but you won't improve that way. So that kind of therapy has been shown to help improve your recovery after a stroke. So those are some of the techniques that some of the therapists do. And then another one is called mental imagery, which basically you are imagining your weak side being able to do the things that you want it to do functionally. Now you can put a mirror there where you can see one side and do what the other side is doing. It's better evidence for this with the arm than the leg. But again, it's trying to find out different things to help that weak side improve. Functional electrical stimulation. These have been out for a while. It's kind of like a robot arm. This one here is called a BioNest, and it basically sends impulses to your nerves and muscles to help your fingers open or your wrist cock back. So it's just another way to try to wake up those muscles so that you can start to be able to do this on your own without the little robot arm. The same kind of thing is available in a leg unit. This particular device sends a shock down your nerve to help your foot be able to raise. A lot of people with strokes cannot raise their foot when they're walking, so they have to get braces put in. But this machine will send a shock and make your foot raise on its own. So that's pretty cool without having that big heavy brace inside your shoe. So these devices are available in different places. Not all therapy places have them, but it's nice when they have them to try to help with improvement in weakness. A lot of people may have seen this. This is similar to the TENS unit. They put electrodes to, again, try to help your arm muscles and finger muscles be able to work with these machines, since your own power is not able to do it just yet. Virtual rehab, so this is basically, y'all remember those games, the Wii Nintendo? So we'll set that up with a big TV and put up tennis or balance games, and it's just some good feedback to try to help with the therapist, help you regain things that you lost. And it's a little bit funner than, you know, the standard exercises that you may get in a therapy gym. This Robotic Technology, this is a big machine that your whole body can fit in, and it helps simulate walking usually so that your brain can kind of get used to what it feels like to walk again. And then eventually the hope is to take this machine away, and then you can start to walk on your own. These are a couple of other cool things. This one is called Armeo. It's made by a company called Armeo. It's another robot arm that takes your own arm's weight away so that whatever little strength that you may have, it can be able to be activated, and then the patient can kind of tap into that strength without their own weight of their arm kind of weighing them down, and then further build on that strength. Okay. And that's just a taste of some of the things that we deal with in stroke rehab. So if you guys have any questions, let me know.
Our first question is, are there any things that can be done to prevent a stroke?
So the main things that you have to do to prevent a stroke is be tight on your medical issues. If you have high blood pressure, that needs to be tightly controlled. If you have cholesterol, you need to go ahead and take that statin. If you have something like AFib, you need to take whatever blood thinner that your physician puts you on. And if you have diabetes, again, tightly controlled, have a normal hemoglobin A1C, and don't smoke.
Could you also talk a little bit about the Freedom Walk rehab that we have here at Memorial and why that's effective?
So that extra part was added about 4 years ago, and it was to help with the occupational therapy task. So we have a grocery center there, like a shopping center. So, you know, people need to grocery shop when you get out the hospital. So that area is to simulate going to the grocery store, getting things off the shelf, being able to focus on what you're actually going to the store to buy. There's another area there for washing clothes or washing in a dryer, different things that you have to do at home. There's another bike out there too, so it kind of gave us a little extra room to put some of those fancy machines on. We have that car out there that y'all probably see when y'all come into the hospital, and that's to practice getting in and out of a car, because that's actually pretty hard. People in Louisiana and Texas have these big tall trucks, and trucks are hard to get into. So we show the patient something smaller at a lower height is easier for you to get in and out of. So it gave us a lot of room to practice different things that we needed to practice with patients that have strokes.